Greetings. Welcome to Best of the Day. My name is Brad Monk, gynecologic oncologist from the University of Arizona Cancer Center, Phoenix. It is my honor to discuss with you uterine corpus cancer clinical trials with my very good friend David Scott Miller from the University of Texas Southwestern. He is the professor and the director of gynecologic oncology. David, thank you for joining me.
Well, thank you for having me, Brad. This is always fun.
First of all, I want to thank you for all of your hard work in, I'm going to say uterine corpus trials because that includes not only endometrial, but the uterine sarcomas and even trophoblastic tumors. And we're going to discuss all of them. But you are also the chair of the Legacy Gynecologic Oncology Group Uterine Corpus Cancer Committee. And I'm here to tell the audience and to thank you for, we have 4 prospective clinical trials to discuss that were presented here at the 45th annual meeting of the Society of Gynecologic Oncology in Tampa, Florida. 4 clinical trials in endometrial. It's unheard of. I love it. So let's get started. I think our audience knows that most endometrial carcinoma patients are treated with hysterectomy. And it is a real challenge when the nodes are negative, assuming the nodes were done, what to do in that setting. So why don't you tell us about the risk factors for what I call node-negative patients in endometrial cancer, and then we'll talk about the randomized trial that tried to address that question. What are the risk factors?
Well, as you may recall in our GOG-99 study, we compared observation with pelvic radiation therapy for patients who were thought to be at risk for recurrence. There was a modest advantage for radiation therapy. We then tried to identify a more high-risk group, or what we called high intermediate risk group of patients. Those were patients who, and it's a little complicated, they had 3 risk factors, either lymphovascular space involvement, deep myometrial invasion, grade 2 or 3 tumors, but it's also related to age. So if you were in this high intermediate risk group, if you had all 3 factors, or if you were over 50 and had 2 factors, or if you were over 70 and had 1 factor. And in that group of patients, there appeared to be more of an advantage for pelvic radiation therapy.
So said another way, stratified by age, which you mentioned, this LVSI depth and grade can also predict those that don't need any therapy. And the opposite of that coin, and also cervical involvement, and also the rare histologies, the serous and the clear histologies. So it's a complicated algorithm, but there's this group of patients, and I think our listeners know who they are. They're the deeply invasive, poorly differentiated tumors, okay? And those patients, I guess, the standard treatment is pelvic radiation?
Well, that's our standard.
That's
our standard
research
treatment.
standard.
That is the research standard for the Gynecologic Oncology Group, and in fact, that was the control arm for our recently reported GOG 249.
249 presented at this meeting, randomized patients to the pelvic radiation versus vaginal brachytherapy and 3 cycles of chemotherapy, which will not only give you some regional control, local control, really vaginal control, but also give you some systemic control with chemotherapy. What a great idea.
That's what we thought.
And so what did it show? How many patients?
600 patients.
600 patients. Randomized. Go ahead.
Randomized trial. So those results were presented. I got my notes here. We had, the goal was to reduce recurrence-free survival, or increase recurrence-free survival from 85% to 92%. We had the 600 patients. So after 2 years, our relapse-free survival was 82% for radiation alone, 84% for vaginal cuff brachytherapy, followed by chemotherapy. Overall survival was 93% for the pelvic radiation, 92% for cuff brachytherapy, followed by chemotherapy. And so in this study, unfortunately, vaginal cuff brachytherapy with chemotherapy was not superior to pelvic radiation therapy.
And you can't really say that they're not inferior or equivalent, but the side effect profile was very different. Tell me about the side effect.
Well, as you might expect, the toxicities were more for the chemotherapy arm, with fever, neutropenia, more common in the vaginal brachytherapy and chemotherapy arm.
And the chemotherapy was carboplatin and paclitaxel. And it was 3 cycles. So how many bowel obstructions? Because that's what we worry about with radiation.
Well, it was a small number, but most patients completed therapy, and as we expect, most of them done well.
So
the only real difference, and it's probably, and I'm sure it's one that our radiation oncologists are going to point to, is that in the site of recurrence, after failing this study, there was 2 in the patients who had the whole pelvis radiation therapy, and 19 in the patients who had vaginal cuff brachytherapy and chemotherapy. The abdominal failure rate wasn't that much different between the 2 arms.
So if the failures are more in the chemotherapy arm, why is the recurrence-free survival about the same?
Exactly. Because our treatments are toxic, though they are survivable, and we are looking for most of these patients, as we know from 99, would probably do pretty well with observation. So the other thing is that we reconfirmed our high intermediate risk groups, in that, again, they well predicted the patients who didn't do well with treatment. Clear cell histologies, papillary serous histologies didn't do well on both arms, or did worse, and patients who had all 3 risk factors did worse. So our hope that chemotherapy would be of an advantage, particularly for the high-risk histologies, we were not able to show that in this study.
So I guess thank you for doing that study, but in truth, I think that controversy continues, and it's still acceptable to do pelvic radiation and maybe even observation and maybe even brachytherapy and chemotherapy. So I think we spent 600 patients to not answer any questions.
Well, that's how we make progress, and sometimes making progress is knowing what not to do.
So if you would have designed the study all over again, what would you have done?
Actually, it asked the question that needed to be asked.
So should we have given 6 doses of chemotherapy rather than 3?
Well, you would have expected that if there was an advantage for the chemotherapy over the radiation therapy, you might have seen a little something in the extra pelvic recurrences. You would have expected that would be different, and then you could say, well, gee, if we'd just given 3 more cycles of chemotherapy, it would have been different. So I don't think we have yet identified a good treatment for high-risk histologies in these high intermediate risk group of patients.
So it calls for biomarkers and clinical trial population enrichment.
Exactly. We have to identify the targets. We have a study that can help us identify the targets, 210. Lots of resources there for smart people to find some targets for us to use. But again, we still have lots of people getting radiation therapy. They took a little poll.
Okay.
And the poll was, what would you do with a stage 1B grade 2 tumor? The answer was observe for most everybody who was involved in the study. However, that was not the choice of the audience. It was everything else.
Right. So if it's all about selection, why are we doing PORTEC-4? Tell us about PORTEC-4.
Well, because if you look
Tell us
at
what
it,
it is, yeah.
Okay, PORTEC-4, and we should go back and look at the little string of PORTEC studies. Previous PORTEC study had shown that pelvic radiation therapy was essentially equivalent to vaginal cuff brachytherapy. It didn't confer a survival advantage one over the other. Toxicity was greater for pelvic radiation therapy, and pelvic recurrence was not that different.
Right.
So therefore, the assumption you would make from that study is that vaginal cuff brachytherapy can replace pelvic radiation.
Okay.
So in fact, if you think about 249 for a little bit, you could almost
what that was.
You could almost suggest that the chemotherapy did nothing.
Right, because of the abdominal failures that you
Right,
mentioned.
it was just another Portec.
Right.
All right, so the Portec 4 study now, which has just started about 6 months or so ago, is going to be 2 dosing strategies of vaginal cuff brachytherapy, and then very important, observation. Right. An observation arm. So we can ask the question that needs to be asked is, does brachytherapy do anything?
Interesting. All right, moving forward to metastatic endometrial cancer, the GOG had validated that the first pretty active targeted agent was bevacizumab, an anti-angiogenesis agent. We wanted to study tyrosine kinase inhibitors. We opened a phase 2, looking at BIBF 1120 or ninditinib, anti-VEGF, anti-FGF, and PGGF, 229K, phase 2. Does tyrosine kinase inhibitor work in endometrial cancer?
Well, we wish it did. It'd be nice if it did.
I paid you all these great compliments about your beautiful studies, and now you're telling me how negative they are.
No, but that's important.
This is strike 2. Go ahead. Tell me your second strike.
Because, well,
how many patients?
Don't be so pessimistic. So there are 32 patients. It was a 2-stage phase 2 trial, GOG trial. Patients who've had previous chemotherapy. So we went to the first stage of accrual with it. Got 32 patients in. The response rate, mainly partial responses, was 9%. The 6-month progression-free number who were progression-free at 6 months was 37%. And that did not quite meet our bar. Now, Dr. Jazan, being the ever optimist he is, even though the study didn't go to second stage of accrual, he will tell us that there's much preclinical evidence that would suggest that if we added Taxol with it and we gave it to patients with P53 mutations, then it might work better.
Great.
So we're hopeful.
So speaking of negative studies, let's move on to leiomyosarcomas.
Well, not just yet, because
All right.
I want you to stand by for ASCO.
Okay.
Because we are going to have a positive 229 study.
With cediranib.
With cediranib.
I love it.
Okay.
So tyrosine kinases are not dead in endometrial cancer. This is a little disappointing.
Find the right one.
Okay. Huh. And cediranib has this great result in ovarian cancer in ICON 6 with a survival advantage, so okay.
That's good.
All right. So GOG 250, leiomyosarcoma. What's the standard treatment for leiomyosarcoma, and then what'd you do?
Well,
metastatic disease.
The GOG has shown, has identified gemcitabine, the combination of gemcitabine and docetaxel as an active combination chemotherapy in leiomyosarcoma over a series of several phase 2 trials. So we then did the first randomized phase 3 trial in leiomyosarcoma, something that many people thought could not be done, but Dr. Hensley got that going. And what she did in patients with measurable, advanced recurrent measurable leiomyosarcoma, GOG 250, it was gemcitabine, docetaxel, chemotherapy naive, with or without bevacizumab.
Okay.
And so, trial was designed to have we were looking for improve the progression-free survival from 4 months to about 7 months. Had about 100 patients. The goal was 130 patients. However, the DSMB informed us that the study was not going to be superior, and it was called for futility. So we confirmed the good news is we confirmed the response rate of gemcitabine and docetaxel at about 36%. Right. There was no advantage for the adding of bevacizumab. But the important thing it showed is that we can conduct a randomized trial of leiomyosarcoma.
And I thought that bevacizumab works in every gynecologic tumor. This is like the first.
Well, we've been trying to educate you.
This is the first negative randomized trial in a gynecologic cancer with bevacizumab. I'm not proud of that.
Well, fortunately, it's just a small group of tumors.
That's exactly right. But the key take-home point here is that patients in unselected, with large clinical trials in unselected patients, given our existing portfolio of agents, are unlikely to yield productive results. We studied adjuvant therapy after hysterectomy and endometrial cancer. We looked at a novel TKI, which many people were excited about. We had bevacizumab to chemotherapy and leiomyosarcoma, and they were negative. I understand we can do these trials, but we need to get smarter, and I think that's an important message.
That's why we're working on a pazopanib trial.
Okay.
Leiomyosarcoma.
There you go. And you got Cediranib in the pipeline for endometrial. Okay. And you're going to do Portec-4 in endometrial adjuvant.
Well, we're going to ask the NCI if they'll support us to do that.
All right, so on a more positive note, the GOG has been able to do, to your point, randomized trials in trophoblastic disease.
The only ones that can do that as well.
I love it. We had one presented at this meeting, and now let's hear some positive practice-changing results. GOG 242, tell us about it.
242. So there have been data from the large trophoblastic disease centers that would suggest in some of these centers that in patients who appear to developing trophoblastic neoplasia after evacuation of a hydatidiform mole, that rather going straight to chemotherapy, some of these patients can be sort of saved from chemotherapy. You don't have to give them chemotherapy by doing a second DNC or a second uterine evacuation. So we designed a very simple phase 2 trial, 60 patients. They meet the criteria for low risk, non-metastatic trophoblastic neoplasia, their WHO score up to 6, and we just wanted to see who it would help. So 60 patients, the important thing, all were cured eventually, but in 39% of those patients, they got their second DNC and they were cured. They didn't need any further chemotherapy.
Single-arm comparator. So this is a group of patients that you say, look, she has persistent trophoblastic disease, it's low risk, non-metastatic, we need to give her chemotherapy. Oh, let's do a DNC and see if that'll fix it. 39% of the time it did.
Yeah.
That's it. That's neat.
Exactly.
And the reason that people don't want to do it, I don't want to do it or haven't done it, is I'm afraid I'm going to perforate the uterus.
Well, fortunately, everybody else was better than you are, because only one uterine perforation, and that was managed conservatively. No patient required a transfusion. And
that's great.
Yeah. So in this group of patients, which, particularly at my hospital, Parkland Hospital, many of these patients are indigent. They have no funding, and so they're hard to follow. And so if you can do a DNC and cure them, rather than trying to get them to come back every week or two for chemotherapy, that's good for society.
So practically, you identify the patient that you think is a chemotherapy candidate. You say, okay, I'm going to do a DNC because the great GOG 242 says I should do it. You do the DNC, and then what, you go back to weekly HCG levels?
Yeah, you just follow them.
And then when do you start chemotherapy? When do you declare that patient a failure?
Well, in our practice, when the HCG level goes up, that's time for treatment.
Okay.
Very simple. 3 non-decreasing levels in a month.
Okay.
That's our criteria. The other important thing was that we didn't really identify any subgroup that this would help.
Huh.
So
Small study.
Yeah, I know. Not related. Did not any significant association with high HCG levels, low HCG levels, the amount of tumor that you could see on ultrasound. In fact, I did one myself where I got no tumor and the patient was cured. And the other interesting thing is that 4 patients, when they did the second DNC, were found to have placentosite trophoblastic tumor.
Now, how do you treat that?
Well, those patients are best treated with surgery.
Hysterectomy, you mean?
Yeah. I mean, there's a few case reports of doing a segmental myomectomy that might work, but standard treatment would be hysterectomy. But those patients also were saved from getting a bunch of chemotherapy that might not have helped them.
Interesting. Well, that's great. Listen, we're almost out of time. I know one of your really key priorities has been to look at sentinel lymph node mapping in endometrial cancer, and Tell us what was presented at this meeting about Sentinel lymph nodes.
Well, we had a presentation from several groups, including the group at Memorial, looking at their experience of using Sentinel lymph node mapping with blue dye, with technetium, and we're getting better at it, is the bottom line.
Injecting in the cervix or hysteroscopic?
Simple. Cervical injection. Simple technique. Right before you start the procedure, you can go on and do your laparoscopic procedure, your robotic procedure. And so the sensitivities of finding the sentinel lymph node and cancer, if it's there, now they're reporting around 90%. And so, this is good news as we try to move forward to doing a large lymphadenectomy trial.
Interesting. So, David, I meant it. Congratulations.
Thank you. I bask in the reflected glory of the genius of my committee.
Well, thank you. And, I am personally a little discouraged that 3 of the 4 trials that we discussed did not meet their primary endpoint, but I do also admit that they're making us smarter. And so even though we didn't change practice, we got more informed, and I appreciate you for being with us here at the 45th Annual Society of Gynecologic Oncology in Tampa, Florida. This has been Best of the Day. So long for now.